Thank you so much for the invitation to be the underdog. And also thank you, Dr. Ritter, for giving us a historical perspective of what should be done today. I'm glad to see that at the start, this was a 50-50. So, it can always get better from there. This is the title of my talk, and these are my interpretation of the talk. So I'm going to talk about fund application preserving reduced hernia repair. So people try to preserve the spleen sometimes. I'm trying to preserve the fund application. My disclosures are here. I don't know if I have 5-7 seconds to do this. This is the case they told us about early on. So my interpretation of the case is that what are the duration of symptoms? 6 months, the patient had the surgery 10 years ago. Is there evidence of reflux? Apparently yes, because of esophagitis. Obstructive symptoms, the patient had dysphagia, regurgitation, and weight loss. So that definitely implies that. Is there an anatomical defect? There is a hiatal hernia recurrence on upper GI and CT scan. And is the RAP responsible for the patient's dysphagia, based on what we know? And the endoscopy did not describe that there was food in the esophagus, that there was food stasis in the esophagus. So it's probably not necessarily the RAP, but we had to give it a shot. So my thought is this patient needs surgery because of the symptoms, but the fact that you can do it doesn't mean you should do it. Like this guy trying to hold those eggs with his arms. The factors that are associated with recurrence of hiatal hernias are not necessarily related to the fund application, and you can see them listed there. And there are certain technical factors in short esophagus like I had in the previous session. So what we know is that the most common type of fund application is the fund application herniation is the most common type of hiatal hernia that we see. When we look at the surgery, they told us that the fund application was intact. So the option for revision in this patient is a reduced hiatal hernia repair, mobilize the esophagus into the belly and the RAP out of the mediastinum, crural repair definitely, and revise the fund application if needed. So what if when we decide to do an intraoperative endoscopy, and we just not base our decision in visual cues, but we decided based on looking at the RAP, and if the RAP looks intact to like the picture on the left, and it meets all these criteria, these 10 criteria, maybe it meets 8 of them, do we need to take that RAP? And if you try to be, a foregut surgeon today, you have to use different tools, and maybe we can use endoflip to see, assess the distensibility of the lower esophageal sphincter using endoflip. And then also there are some studies demonstrated that the crural repair is what's shown a bigger impact on distensibility of the LES compared to the fund application. So again, fund application preserving surgery, when and why? If we have an anatomical, normal appearing RAP with a good endoscopy, and then we have good distensibility on the endoflip, maybe we can do cruroplasty, maybe add a stitch and then get out. Partially disrupted RAP, maybe we can do the cruroplasty and a stitch. Partial takedown of the fund application because the patient had dysphagia. If that's the problem, doesn't seem to be the problem for this patient, but it could be. Or patients that are too high risk to undergo a significant takedown of fund application, that we can just do a gastropexy and get out. This is based on intraoperative findings. And then a word caution in taking fund applications done. I'm sure many here have done it, but it's some of the most complex portions of the operation along with the hiatal hernia repair. And you can see in this study from a conservative or conversion fund application from France, of the 73 patients that had recurrence, 35% of patients conserved the initial fund application, and some others were converted to Nissen fund application. So there is some literature on this. And then don't forget that there are technical challenges associated with taking the fund application done, like esophageal and gastric perforations that could definitely represent a conversion or a patient that is going to have a leak. This is a little more data in terms of this systematic review. 21% of intraoperative complications, and many are intragastric and esophageal perforations. So in conclusion, I think the surgical plan should be tailored to each patient's specific needs, and may include reduced hiatal hernia, palliative options such as the gastropexy I mentioned earlier, and takedown of fund application if needed. even though most experts would recommend the takedown of the fundoplication to reinstate the normal anatomy, it is paramount. It's not paramount to the repair of the hiatal hernia, definitely. So redo operation does not always mean redo fundoplication, even though the literature is like this. In selected cases, intraoperative decision can be made to preserve, repair, or convert the previous fundoplication, potentially decreasing complications. Redo surgery along with takedown of previous fundoplication has shown increased morbidity, specifically, as I said, esophageal and gastric perforations. Thank you so much.